On the grounds of Mamelodi Hospital, there's a symbolic tussle going on. To stay clean or to allow drugs to triumph over wellness and treatment. This is a branch of COSUP, a community treatment program for people who use nyaupe and heroin.
Yes. And then my name is Jabu. Yeah, and I am beautiful. Yeah.
Nyaupe is a concoction of heroin and dacha and whatever else illegal drug makers add to it. It's injected or smoked and is said to have first popped up 20 years ago in townships like Mamelodi.
It's easy to be tempted because whenever you just go out that side of the yard, they are here. Or it is so like sweet. I came in with that heart saying, I'm going to the right place. I know they're going to help me.
Nyaupe is what's brought Gaugelo Baloyi to COSUP.
Come in.
He became dependent on it. He's new to this program, which uses methadone to wean people off heroin. Methadone curbs heroin withdrawal symptoms and is only taken orally, so there's no sharing of needles. When needles are shared, users can transmit HIV and hepatitis C to one another. To the brain, methadone looks like heroin, but doesn't cause as much of a high. So if you don't get another dose soon after the high wears off, your body doesn't crave it as much as with heroin. This is called opioid substitution therapy. It's safer for Gaugelo to get his methadone under watchful eyes here at COSUP than to take his chances with street heroin.
The medication, it is better than the substance I was taking in terms of finances and then in terms of the way I was living.
People on methadone are generally more productive than people who use heroin. Gaugelo says he's regained the trust of family and friends because he's no longer roaming around looking for drugs or hustling for money.
Although they are still having these doubts, whenever I can go like 5 hours not being visible in their eyes, and they will start like checking where it, having to be smoking but anyway, they are the pillars of my health.
COSUP is run by the University of Pretoria and funded by the City of Tshwane.
So from those humble beginnings in 2016, it has grown because there's always a need. There's more and more substance use in the city. At this moment, we have about 850 to 950 clients treated every month at COSUP at the various sites.
Vugab Telezi manages medicines for the 16 COSUP centers in Tshwane.
COSUP issues around about 130 liters of methadone every month. So that needs to be controlled and managed.
Social and health workers visit areas where people who inject drugs hang out.
We provide something that is called a street medicine. We do HIV testing. We do as well, abscess care and wound care because we know that people who use drugs are sometimes using injections, and that is a big part of our programs.
They sometimes have to reuse a needle, which becomes very problematic for their skin. We limit the number of abscesses that they have to deal with by offering sterile needles for use every time they have to inject.
Gaugelo comes to COSUP daily for his 6 milliliters of methadone. He seems determined to stay off nyaupe and eventually wean himself off methadone.
Try to hurt yourself. You can be that person you were before. Let me go back and be that somebody. Start being positive with everything I do.
Andrew Schreiber is a medical doctor who works in harm reduction research and policy. He joins me online. Andrew, what is harm reduction?
So when relating to drugs, it's the policies, the practices, and issues that can help a person make healthier decisions, and it doesn't necessarily require the person to stop taking drugs. It helps the person to make decisions and to be accountable and really provide access to services.
So there's a lot of evidence that one form of harm reduction, methadone to treat opiate addiction. There's so much evidence that it's on the World Health Organization's list of essential medicines for this purpose. Yet it's only available at very few government clinics in South Africa. Why is that?
So there's no doubt in our National Department of Health's perspective that it works and it needs to be done. The challenge at the moment is getting the medication listed on our essential medicines list for that indication. Currently, methadone is available in the public health sector. It should be at least in all hospitals, because when people are admitted to a hospital for any reason and they have opioid dependence and they go through withdrawal, the government recognizes that people should be treated with methadone to avoid the withdrawal so that they can have their other treatment. The challenge so far has been that our primary healthcare platform is not yet being tested to be able to provide that service where it's needed.
You've mentioned that one of the problems is that methadone is not on our essential medicines list. What needs to happen for it to be put on there?
The Essential Medicines List Committee have reviewed the evidence and have said very clearly that it works and it's needed, and they've given a recommendation to the National Department of Health to collect data on the feasibility of doing this in a primary care setting. This recommendation was made 3 years ago, and now the Department of Health has put out a tender to do 2 pilots. It's a very small number, but the idea is it'll show how this will link into our context, how the services can adapt to providing people daily treatment initially, how the training needs to adapt to our context, what materials and tools we would need to monitor patients and keep them safe.
Some people would say, why would you make it easier for people to do something illegal? How do we get around that?
Moral judgments or personal perspectives of drugs or anything can prevent people from accessing life-saving interventions. We've got very good data to show in the City of Tshwane, where the needle and syringe service was stopped for 2 years, how now, since we've done another follow-up study, the HIV burden is much higher and the hepatitis C burden is much higher. So it's this recognition that as public health individuals and society, while we might not agree with something, we want and have a responsibility to keep people alive and enable them to have access to services.
Something that often prevents us, other than morals, to roll out harm reduction programs is cost. How expensive is it, and is it more expensive to not treat or more expensive to treat?
There is very good global data to show that needle and syringe programs are cost-saving. They're one of the least expensive public health interventions. And we're not talking very, very large numbers. We're talking a notable number of people who inject drugs, potentially around 82,000, perhaps more in South Africa. But with every person who becomes HIV infected, we have large numbers of people who need lifelong treatment, increased likelihood of TB treatment, increased likelihood of transmission to other people, elevated risk of death.
Can addiction be cured?
It's very important to think of it as a chronic condition. So like hypertension, can we cure hypertension? Can we cure diabetes? Some people may shift their life that's no longer a problem. So it helps to think of it that way. Medical aids should be providing these interventions because they're cost effective.
Do medical aids provide them?
They don't. They do 21-day with inpatient withdrawal, which is very expensive. It doesn't work. It's actually not recommended because if people come out of one of those 20-day inpatients, they lose their tolerance. If they return to use, they've got an increased risk of overdose. If they inject and they use a contaminated equipment, they've got an increased risk of HIV and hepatitis C.
Andrew Schreiber, thanks for joining us.